a suggestion or a request from you, our listeners, from the field as I travel across the country. So really, educational partnerships can create magic. Getting a view of how things are really changing in the industry requires us as MSPs, as well as all other healthcare workers, to look at things in a way never considered before. And Nicole and I want to help you with your mind stretch by describing for you how the role of the MSP in healthcare quality data management can really create that link between physician and organizational quality and reimbursements. And then we're also going to identify for you the value-based reimbursement models that exist to better help you understand all of the moving parts behind healthcare organizations and how they really stay in business. Now, as Nicole said, remember, there's a lot of new information that we're going to be funneling your way. So take it slow, and really, after the program and you get your PowerPoints, refer to those PowerPoints as a resource for you that you can go back and, oh yes, I remember Donna or Nicole mentioning this in that webinar that I attended. So this session is really specifically going to be highlighting on the macro concept all of the key moving parts, as I mentioned, about how healthcare linkage between physician, practitioner, and organizational quality and revenue matters, and other sessions that we're going to be hosting down the line will give you more of the drill downs and the how-tos. So keeping that in mind and in prep for today's lesson, this really is your first step in pushing yourself to learn something new. Now, we as MSPs have to learn something new almost every day. But what Nicole and I are presenting to you is really a totally different way and manner and participation you as MSPs can have in this healthcare model called quality. Learning something new is not really new for our industry. We've harnessed the measurement of MSP competencies just looking at the model that's before you. And my colleagues and I show this model at every one of our programs because we're really trying to put structure around what we do every day. The knowledge we acquire through programs like this, the skills that we practice, and our ability really to demonstrate that to our key stakeholders, our supervisors, bosses, and executives. When we look at competency, we look at these three pillars, but specifically I want to advance you to this slide. There are 17 core competencies that we in the MSP world or medical staff services world really need to have a working proficiency in. Not all of these might track directly to your work environment, but in total, everything that an MSP would do would touch one of these areas of competence. The one that's highlighted today truly underscores the topic for our program today, and that's the Healthcare Quality Data Management Initiative. And when we look at how that fits into what we're currently doing as MSPs, this slide, again, the higher level picture of what we do as it pertains to quality. Currently, we as MSPs facilitate, gather, organize, submit, kind of even facilitate some discussions with our operational leaders as well as medical staff leaders regarding quality. Quality relative to the competence the practitioner is in requesting a particular privilege, what that means from the FPPE or the Focused Professional Practice Evaluation component of our reviews, and then the ongoing things that we collect on a regular basis in the hospital setting, quality data that we collect on a regular or routine basis and used at time of reappointment. And then those things that are being handled at the peer review level, which includes also behavior issues. And again, there's a lot of structure, a lot of policies under each of these bullets, but we're trying to give you a contrast. Currently, this is what MSPs do relative to quality management in organizations. What we're asking, Nicole and I are asking you to do, is look at it more broadly, right? This is how we as MSPs can become more involved in the data, the management of quality data in our organizations. So it's really how we can use data relative to physician performance and map that or align it with reimbursements, how that practitioner is performing and how it maps to the reimbursement that that practitioner is going to receive based upon their outcomes and performance, as well as the organization. So using that concept, everybody who touches a patient, has a patient experience, provides care, really has a stake in the reimbursement, the optimal reimbursement that an organization is going to achieve. And we have to be sure that we understand that health plans, whether it's Medicare, Medicaid, or commercial health plans, play a part in this data collection, as well as whatever your internal organizational structures are, whether they're software programs or manual collection of data, but how this data is being collected. So we as MSPs, this is sort of the door opening into, tell me a little bit more about what the shift in healthcare quality looks like. So opening that door a little bit more, it's really about linking medical staff, practitioner data with your organizational data. And how we as MSPs can be one of the linking factors is we first need to be understanding better what this all means. And then we can have more informed discussions when you hear administrators or medical staff leaders speaking about this in your organizations. So we want to be a conduit for education, not only for ourselves, but our stakeholders. We want to be able to provide valuable resources to the same stakeholders. We want to be able to help our administration as well as our physician leaders to establish what those quality expectations are going to be. So when an applicant applies or reapplies, they know that this is what's going to be expected of them by way of performance, outcomes, as well as optimizing reimbursements. What those financial, so it's not only the quality expectations, but it's also the financial goals on a particular initiative or disease order or hospitalization coding. So all of these things that we knew as MSPs more from a distance, we heard about it, we need to take a greater interest in having a better understanding how these really do correlate to reimbursements to our practitioners as well as organizations. We then want to be able to facilitate the mining of all of the data that we know is being, or maybe not quite yet know, but that's one of the exercises that we want to do, is reach out internally to our organizations to see who is all collecting what data, so we can then determine with our leadership what things the medical staff leaders or organizational leaders need to evaluate continuation of their membership or of their granting them specific privileges. We also, now Nicole excels in this area in her ability to analyze data that comes her way. That's not one of my strengths. So having a working understanding that analyzing is part of the process, but we don't have to be clinicians. We don't have to be finance finance experts or data experts to do that. It's sort of the higher level, just as in a sense we're doing now when we know that there's a deviation at time of reappointment on a practitioner's profile. We highlight that for the medical staff leader or for the members of the credentials committee. So when they're making recommendations, they're making them based upon informed information, being informed. We as MSPs have to have a knowledge and an understanding and a competence about writing needed reports. So when the evaluation piece takes place about applications and about privileges, the FPPs, the OPPEs, and reappointments, again, we're being the facilitators for our administrative and medical staff leaders regarding performance as well as revenue, or I should say outcomes or financial data. So that's the big picture of how we as MSPs can better help facilitate the link between quality and our organizations and medical staff. But what do we need to do as MSPs? How do we really prepare? Because gosh, Donna, this is what I hear frequently. Nicole and I presented a topic similar to this at the Las Vegas show in the engagement session by symplr back in February. And questions that we would get from the audience is, gosh, Donna, this is it's sort of out of bounds for my thinking. I'm very familiar and competent in what my role is relative to what I'm doing in the medical staff services department or in my practice management area working with my practitioners. But some of this information, I'm just not sure how it all fits together and where I fit. So in order to prepare you, Nicole and I really wanted to kind of lay out a map for you on how you can prepare yourself for success. First, it's about being a self-learner by attending programs like this and other healthcare quality programs that you may see come across on your email chain. Talk and network with others. Read articles that you might see come through again, maybe on your LinkedIn feed or your Facebook feed, and then attending various meetings and not sticking with the norm credentialing, which are valuable, the credentialing and maybe legal cases or maybe CVO management. All of those are certainly important by way of our industry. But again, what Nicole and I are introducing you to is that there's a whole nother scope of information relative to quality management that we can begin embracing. The next thing we're suggesting for you to be involved is to join a task force, just like the theme of these educational programs that symplr is hosting. You really, just by registering and participating in this webinar, you are already a member of the task force because we can learn from one another. Oftentimes, we will get questions at the end of a program or privately sent messages to your speakers. So we translate that information into new information that we can share at future webinars or educational programs. So it's really about working together as a team. And so we have these invisible boundaries and walls. So we really are approaching this as a team effort. If you know that your organizations are hosting quality teams, volunteer or ask how you can get involved. And initially, think about when you first became a part of the medical staff services industry. Lots of acronyms, lots of terms that you weren't familiar with, but just through time and working with it, you became more knowledgeable and you basically mastered your credentialing skills. And that's the same challenge that Nicole and I are offering you relative to quality. And then know your stakeholders, because every one of those groups that are listed on your screen are part of this healthcare quality initiative. So we don't necessarily see medical staff services on here. medical staff services departments. But we as MSPs, we have interfaced potentially with many of these. And if not, how can you get involved? So networking is going to be really key to embracing the components and the depth of this healthcare quality management initiative that Nicole and I are offering. So when we put this structure around all of the different things that we as MSPs need to know under this new core competency referred to as quality data management, it's really about advancing your knowledge. We as MSPs, we need to be part of or responsible for designing an integration plan where we can use medical staff or physician practitioner performance data and map it with, again, that reimbursement or their utilization data. We want to be able to write policies and procedures that describe what that integration looks like and how it will function. We want to be able to either utilize or develop what reporting tools are going to be used in this process. Some of these may be software driven, some of them may be Excel sheet driven, some of them may be access-based driven, some of them might be Word documents. But irregardless, we want to be able to identify how we can make this process as technologically driven as possible. We want to be able to generate meaningful reports. So right now, if you know that you're not utilizing your credentialing software to its greatest capacity, being able to generate meaningful reports is going to be equally as important from the quality component. So making sure that if you know that that's not one of your strength areas, start with the credentialing software database first, because you have, like I say, you've mastered that. So just drilling down, asking your software vendor how you can better understand what kinds of data you can pull from your credentialing data source. We want to be able to, and again, Nicole excels in being able to analyze statistical data, but we as MSPs don't naturally have that skill set. But we want to be able to interpret high-level data, areas where we actually see gaps in performance or outcomes or behaviors. We want to be able to identify that. So again, we're helping our medical staff or administrative leaders, which takes us to the next bullet point. It's really what we do now is guiding our administrative medical staff leaders and our boards of directors in helping them make informed decisions with regards to credentialing and competence in performing privileges and some quality information, but we're wanting to expand our role of facilitation. So I'm hoping you're seeing through all of these examples how our role as MSPs can really become even more valuable in our current organizations that we work with. And then actually facilitating any corrective plans or performance improvement plans that might be presented to a practitioner, and always documenting that activity with regards to correspondence, meeting minutes, etc., in the appropriate resources, i.e. a quality file is usually where I see documentation of this sort. With the collection of all of these elements that I've presented to this point, it's really not about dinging a doctor. It's about giving physicians and practitioners the right information in a uniformed and consolidated fashion, so they really understand where they're measuring based upon their performance, aligning it with any areas of discrepancy or outliers that they have with peers, and then industry standards. So understanding again that the goal is always to try to help practitioners improve their performance so everything is moving in a positive direction. As you know, physicians and practitioners, along with MSPs, we can feel pretty beat up at times. So what we're asking, Nicole and I are asking you to do, is really approach this new initiative with a positive spin as opposed to the same old, same old. Help them understand that this is a new way that the doctors can really see themselves, not in a fragmented standpoint, because quality's collecting this, medical staff's collecting this, the credentials committee has this, your VPMA is collecting behavior issues. It's all going to be pulled together in a uniform fashion in a logical profile. So not only the committees can make proper decisions and administrators, but also having that tool, that resource and education tool for the practitioner. So with that,
can I jump in just 1 second, because I think that what we've seen is that we've moved away from fee for service, and basically what that means is being paid for a procedure, no matter what the outcome is for the patient or how well the practitioner did that or provided that service, into performance models, right, or paid for performance. So in the past, we've really used quality or performance pieces, like Donna said, as punitive or kind of the stick, right, versus incentives in the carrot. And what I believe that moving towards a paid for performance model, it's not about the stick anymore. It's about how do we incentivize, how do we support, how do we lead our physicians towards a culture of learning and growth for themselves. And I think that, as Donna mentioned, we are that support structure as MSPs between our physician group, whether that's the medical staff or whether that's, who's enrolled in our network or who's in our practice group, leading them towards the best quality of care, because it's in the best interest of the patient, but it's also in the best interest to the bottom line or the financial piece.
Excellent. Thank you for adding that description, Nicole. It further underscores the next slide, actually. Why? Because as I mentioned, Nicole and I frequently get this question. Donna, Nicole, why do I have to know this? I have so much more other things that I'm trying to do in my department. This is just sort of like another whole responsibility. But the why, Nicole will really do a wonderful job walking you through the whys. But really the bottom line why is as professionals, as executive performing MSPs, this is another notch in your belt to make you that much more valuable to your organizations and to increase the marketability of the talent that you already possess. So Nicole, can you please help walk us through the statistics that are referenced?
Of course, and data-driven decision-making, right, is something probably we've all been hearing. And so all these stats kind of are accumulation of what's going on in the healthcare industry that supports the why behind us getting involved with value-based models. So as we know, healthcare expenditures are only increasing. It's at 5.7 trillion by 2016 is the estimate. The growth rate of about 5.5% each year. That is incredible. So in 2016, healthcare spending will represent 19.7% of the nation's income. That's in the United States. Next slide. So private insurance spending will decrease because of baby boomers between the years of 21 and 26 by 4.7% as they get enrolled and utilize Medicare, which is obviously a federal payer. Next slide. We do see 72% of millennials reported health insurance costs as a cause of stress. 61% of baby boomers also said that it was a cost, that the cost of healthcare was a cause of stress, and 51% of older adults. So once again, this is really impacting the mental health and the physical health of our country. hospitals that keep operating business as usual, which we do see across the system, people saying, you know, this is CMS's flavor of the month. You know, it's actually not going away, and they will see their margins or their financial health decrease by 15.8% by 2021, which, as we know, that percentage right there alone would make a hospital system possibly not viable or sustainable, right? They may have to be acquired by a larger entity, or they may have to shut their doors, which does impact, obviously, us, our providers, and the patients in which we serve. There is an increased need for technology with high level of data analytics capabilities. So what we are seeing is that market is growing at a rate of 12.5% per year. And so once again, kind of like we've been saying over the past 10 years, technology isn't going away. We understand that as we automate, as we use artificial intelligence, telehealth is big right now. What we're trying to do is we're trying to navigate away from human pieces that could cause human error, etc. And that's the same thing with our data analytics as well. Is what we're trying to do is we know that we have all these different systems within IT systems within a hospital, within, you know, a payer, within a medical group that need to talk to each other to generate meaningful information, right? So if we're moving to a performance-based payment model, we need to know how that performance is connected with our contracts for each payers, and then how much money is coming out per the volume in which each practitioner is doing, but what our group is doing. And that data analytics is also going to be used by payers and hospital systems, et cetera, to also analyze how does a group of particular maybe department measure up to the same group within a different hospital within a system, and how do we learn and leverage the individuals and or groups that are excelling to really pull up the groups or individuals that are not meeting performance standards. So I know it's so complicated, and I know that's a lot of information. But what we really need to do is we do need to understand the why before we move forward in anything. So as we look at payers, I've mentioned that quite a bit. You have the Healthcare Transformation Task Force that got established in 2014. Their members, which include Aetna, the Anthems, the Blues, the Kaisers, so they're a part of this group, and they're saying that they are committed to having 75% of their respective business in value-based payments by 2020. That's next year. So this is something that we have to take a step back and say, oh my goodness, 2020 is next year. I bet my healthcare system, my organization is involved, if not in process of developing a value-based model. And how do we get involved in that from, like Donna was saying, a quality perspective? You know, value-based care is expected to account for 59% of healthcare payments by 2020. That, once again, that corresponds with the Healthcare Transformation Task Force initiative and commitment. By the end of 2018, 65 billion will be tied up in value-based contracts, and that's United Healthcare. And as we know, United Healthcare and the Blues, et cetera, they kind of rule. So Blue Shield also says that they are working, you know, especially in California, for accountable care organizations, and they gained 325 million cost savings. And so that is an actual reported number of cost savings because of value-based model. Medicare, as we know, impacts all of us, and Medicare impacts also the commercial payers. And Medicare is committed also to value-based models and in enrolling programs. And that's what we see in the MACRA and the MIPS and other kind of programs that are Medicare or CMS based. So healthcare issues, kind of going on back onto gathering data. We can put them in 6 different buckets, and we're going to go in depth a little bit more on each of these. I'm looking at the clock, and I really want to make sure that we have time for questions. So let's move on to our first issue, which is ensuring a strong financial future in an unstable health economy. Factors. We know that we have an aging and growth population. Developing markets expansion, we see all the time. Technology, we know, is kind of the rule. Next slide. Thank you. And so rising labor costs. I don't know if you walk the halls in your institution, especially if you have physicians, but reimbursement is decreasing and the cost of actually operations, which includes labor and other things, is rising. So once again, we're doing the same amount of work, if not more work, for less. Disruptors, personalized medicine. We know that it's a consumer-driven industry. Technology, we touch on all the time. Competitors. What we're seeing is a lot. I hesitate to use the word monopolies, but we're seeing the number of competitors decreasing and large entities expanding. So the big organizations are getting bigger, and the small organizations are either dying or being absorbed or by a bigger entity. The expansion of delivery sites. So instead of maybe having your surgery done in a hospital setting, you're now going to a surgery center. And once again, kind of like what we're talking about is kind of the revamping of payment models. And then solutions, health technology, that's telehealth, et cetera. We hear mergers and acquisitions and partnerships across our industry, probably on a daily basis. And alternative revenue sources, right? So what we saw with the shift from all the monies kind of coming into a hospital, we really want to keep patients out of the hospital, and our money centers are really in our medical groups. So adapting to change, because everything now is driven by consumers. We all probably are very familiar with patient expectations and the surveys that we get and how that actually impacts our reimbursement rates. Now, I hope you guys know that it does impact your reimbursement rates, but also how it drives high-level decision-making within your organization. Patients and caregivers are consumers, and they are demanding change. Poor service, lack of transparency. We see a huge shift of health grades, right? Or even CMS has a very transparent website where you can go and see how healthcare facilities measure up to one another. We are trying to change the way in which we treat patients, right? Preventative care is what we're looking towards. Once again, going back to trying to keep patients out of the hospital. And from a point in time where we really treated a disease versus a person, and we're seeing that once again being driven by the consumer, by patient surveys, et cetera. We do have solutions to this. I don't know if your board includes a patient advocate. We do have community members that sit on a lot of our boards with the hospitals we're involved in to help shepherd decisions from the consumer perspective. And we're also engaging in proactive models, once again, trying to keep patients out of the hospital as much as possible. And you guys are all probably very familiar with that, and each hospital system or hospital in themselves has a different approach to that. Next slide. So improving access and affordability, and that is what the main goal is of our value-based care delivery models. So kind of like what I touched on before is we're moving away from a fee-for-service to a value-based or a performance-based model. This requires payers and providers to collaborate with one another. This requires us to share information. And once again, as we talk about data in general in systems, is we have data in various places, and so how do you integrate that? And we are really going to have to leverage that IT analytics support, because we're not, as Donna had mentioned, we're not tasked with that to analyze. What we are tasked with is to be an active member in supporting performance and how it really relates to reimbursement. Physician top benefits, improve patient access to care and patient satisfaction, and really staying connected with not only the patient, but the caregivers, and I would say beyond that, the community. I know that there is no physician, no healthcare system out there that doesn't want to be recognized by the community that they serve as incredible providers of healthcare. And then we really have to look at, as we look at access and affordability, what does virtual health look like? I know that in the Midwest, there's a large hospital system that will respond to emergency calls with a EMT harnessed with a computer that can call into an ED doc, a provider, so that the provider can speak with the patient in their own home where they're at to determine whether or not there is reason to get them from their home to the ED, or whether they can wait to stay outside of the hospital. I know that we all struggle with that, because just like you saw this morning, we do have IT issues. And so what does that mean to patient care if we're doing this virtual health or telehealth piece? Next slide. I won't even go here, but regulatory compliance and cybersecurity management, this is an issue for all of us. Once again, just like we see acquisitions and mergers in the newspaper every day, we also see HIPAA violations and big monetary amounts being paid out by large systems, whether that's even a healthcare system or even a contracted entity like an IT software. So this is something that we really do need to be mindful, and as we go out and try to increase access and affordability with technology, what does this mean for the protection of the information that we have for patients that is protected? So moving on to top talent recruiting, development, and retaining. I am involved in our recruitment of physicians and staff, and it is extremely challenging right now. There's a high increase in demand and workload, but also a desire from millennials to, I think you're a couple slides, maybe I missed a slide. So can you go down to retention? We won't talk about digital innovation and transformation. So talent recruiting, development, and retaining, this is a huge thing right now, not from a physician level and a staffing level. And this is something that we are really going to have to be mindful about. symplr does some really incredible webinars with one of their other contractors about physician burnout, and that's something that TEMA Global also talks about. But we also talk about MSP burnout and employee burnout in healthcare, because once again, we're all doing more with less. And so this is a huge thing that's driving the desire to increase reimbursement by performance. Next slide. So as we look at kind of the trends, continue movement forward, a financial model based on value rather than volume. We've seen that for the last 10 years. Some are slow adopters, some are early adopters, and some, once again, are that bird that buries their head in the sand and hopes that it goes away. And once again, it's not going away. And we are also seeing smart health communities, where communities, health systems are coming together and really trying to work together for value-based models that benefits the whole entire community of healthcare. So value-based reimbursement, real quick, because we have 10 minutes and I really do want to save some time for questions. So I put this in here last minute, and this is just kind of where we're all going. And are quality performance metrics tied to your physician compensation plan? I mean, and that's a really good question to ask, especially as we work in organizations that have employed physicians. And or even your contracted ones, are those tied to quality metrics, and are those quality metrics tied to the reimbursements in which they get, or contract fees in which they get? And as you can see, we keep on seeing an increase from 2018 to 2019, where our unsure went from 4% to 2%, and that 2% went into the yeses. And then we see still a lot of people that say no. I will tell you that a lot of those no's, though, are working on redefining how they compensate their physician based off performance. So this is a really great slide for you to go back and kind of look at what's the difference between fee-for-service or population management, or what we would say value. Next slide. So value-based reimbursement, what you need to know. I really do want to get to the following slide, but basically what you need to know is that it's for performance and not for the service. So it's outcomes. It's not driven by the volume of services provided. New skills and capabilities are needed to manage the risk under value-based reimbursement models, right? So if your data is bad and that goes to a payer, and the payer decides to reduce the cost for that service, then it's a slippery slope. So you really need to manage that in a different way than we have volume, right? And then there's a lot of shared risk models. And shared risk models are where the entity itself, so your hospital, your medical group, will take on some risk, but also the payer is going to take on some risk as well. Because if your group does really well for a service, it might be an increase in payment, not a decrease in payment. And then physicians need to participate in these models. So looking at the type of models, we do kind of have a hierarchy here. And the QPP, which is the Quality Payment Program, and this is a program with CMS oversight, really separates into MIPS and APMs. MIPS is primarily for smaller medical to medium medical groups. Their goal is to work from MIPS to an APM, which is an advanced payment model. And all these, I want to tell you, are value-based models. And you can see kind of each of them that are stacked up again, underneath the APMs. A lot of us should be familiar with some of them maybe not. ACOs have been around for quite some time now, but there's actually stages of ACO. So it's not good enough to just be an ACO. What you need to do is you need to go from a track 1, and there's actually track 2, 3, and then the goal is to push all ACOs to a next generation ACO model, which once again, as you kind of go down this hierarchy, you're getting more and more to taking risk on both sides of the fence for performance, not volume. So CMS 2019 participation, you can see on the other slide, it significantly grew from the years prior. And so there's a huge push from CMS to get individuals and groups enrolled in value-based models. So 2019 most impactful changes, we did see an addition of eligible health professionals. So chiropractors are now included in that, clinical psychologists, audiologists, speech language pathologists, occupational therapists, physician therapists, and dietitians. And so just keeping in mind that it kind of started with our lump sum of kind of the what we would consider the standard MDDOs and some allied health professionals, and now it's truly expanding. You get to elect to participate if you were excluded due to low volume. They're actually forcing your hand because you get to do virtual groups now where you get to be linked with other like practitioners so that you can meet performance thresholds. And specific performance categories are changing and if or not getting tougher. So once again, they're trying to start out at a very base level, but they're trying to increase their incentive and increase their performance. Incentives and penalties are decreasing. Once again, it's really good for everyone to know is the data that's being reported out, the penalty or incentive will take effect 2 years after your reported data. So 2017 data is now taking effect into your 2019 payment. So once again, going back to 9%, that is a substantial amount of money that could move an organization either to closing their doors or having them have to make the decision to be a part of something, a system bigger than them. So smart health communities, it gives you kind of a description here of what those look like. And we do see a lot of communities moving forward in really engaging stakeholders outside their system or their organization. As we move on to the next slide, U.S. healthcare trends. You know, we should be watching for the following trends: collaboration between health systems and health plans. We see that once again those are something that's always in the newspaper about a health system partnering with a health plan. Shift to wellness rather than illness. What we want to do is we want to get patients well and we want to keep them well and out of the hospital. Technology is going to help create a more patient-centered focus. And then we are really going to have to adopt virtual care options because the overhead costs of actual physical buildings is restraining access and affordability at this point in time. And we really need to look at what's best for the whole or population health and not particularly maybe what's best for the individual as we move forward. So small things.
Yep.
Yep, small things start us in the new ways of thinking. So this is, you know, I know we kind of went through this, especially this end part very quickly, but once again, you know, these are really content-rich slides for you guys to take back to your organizations, to your teams, and really digest it. And this is just the foundation knowledge needed to go back to what Donna was saying, ask the appropriate questions, get involved in the appropriate teams, and align physician quality measures that are connected with privilege forms in the medical staff office with those measures that are connected with reimbursement. Because at the end of the day, we're going to be paid for performance. And if we're going to ask a physician, we're going to track physician measures, they should be aligned across the system, whether that's quality, privileges, medical staff membership, and or reimbursement.
Wonderful. If anyone has any messages or questions, you know, please enter them in the dialog box. And then I'm going to reveal the slide for Alex to do just an announcement about the next engagement session.
Yes, thank you, Donna. We're really excited to announce, we're just going to take a quick commercial break here before we get to questions, but our next user conference is coming up in Boston. That's June 6th and 7th, and this is free for symplr customers to attend, and you can earn 9 NAMS CEU hours completely free. You'll also have the opportunity to meet one-on-one with key members of the symplr team, anyone from professional services, the product team, even our senior VP and general manager, Amy Teskey, will be there, and you can set up time to meet with her. If for some reason those dates don't work for you, or maybe you particularly are not a fan of Boston, we have 2 additional user conferences this year, all of them free to attend. So we'll be in Denver, September 19th and 20th, and then Nashville, December 12th and 13th. So if you're interested in attending, you can visit symplr.com/engage right here on the slide, or you can email us at communications@symplr.com. So that's communications, and again, symplr is SYMPLR.com. So now we can open it up for Q&A with Donna and Nicole. So if you haven't done so already, please type there in the chat box. We will also be providing a link via email of an archive of this webcast. You can download the slides there as well. And then in a separate communication, we will be sending your CEU certificate to you. So to make sure that you get both of these emails, please add communications@symplr.com to your email address book. So let's see, we have a question here. Donna, you talked a little bit about task forces in the beginning. Do you know of any other affiliations that host webinars or educational meetings on this topic that they can log into or sign up for? He said that he knows CMS sends out alerts at educational sessions.
Yeah. Now, Nicole, because she is more integrated into quality, healthcare quality, from her perspective in her vice president or administrative role, in her organization, I'm going to ask her if she can recommend any other courses. I love the level of interest. So this is great. This is one of the things that Nicole and I were attempting to do. Whether or not there's anyone else in the medical staff services industry talking on topics like this at this level, meaning the MSP level, I'm not aware of any other than this being sort of like the maiden voyage of this topic being presented at for MSPs and quality managers, enrollment specialists, etc. So Nicole, from an industry perspective relative to quality, are you aware of any?
Yeah, going outside of the MSP circle, I would recommend the National Institute of Health is one. There is also more of kind of administrative groups like associations connected with practice management groups or hospitals. And then there's also, like you said, CMS, but a lot of the payers also have webinars. Health Catalyst has some great ones. Healthcare Catalyst does. And what I can do is I can send kind of a link to organizations that have webinars like these to Alex, and she can send that out with the material because there are different groups, and based off of who you are or what role, like where you are in the industry, one group might be more applicable to you than another.
Okay. And Nicole, I just have another idea. I think it's great to send it to Alex, but please include me on that, and I know you will, and I'll make sure it gets posted on our website within probably
a great
early
idea.
Next week. Okay.
Yep. Or you can check out TMG's website.
Now, also, Alex, do we have any other questions?
Yes, we have one more question, and that is, how do we convince older clinicians to change with the times with increased need for data and quality of outcomes as an MSP? It's a great question.
Yeah, it is a wonderful question. And Nicole, I'm going to take a first stab at this, and I'll ask you to kind of chime in, okay? I think that that's a reality. We, especially if we're in the medical staff services realm, we feel the pain of so many of our practitioners. They have some of the same reactions that some of our colleagues as MSPs have. Why do I have to learn this stuff? Why can't I just practice medicine? But things have changed. And one of the things that Nicole and I showed on an earlier slide, the goal truly for all of this is for us as MSP professionals, as payer enrollment specialists, quality managers, we want to reframe this whole component of quality, performance outcomes, and finance. We want to reframe it in a positive way, because every doctor who performs their work, they want to know that they're doing it. They want to have a sense, a belief that they're doing it with the highest of quality. So how do they do that? Because everything that's coming to them by way of data is so fragmented, it's hard to even paint a picture. And then the data that they're being given, oftentimes they question. So I think it's mainly just that ongoing education for us to be most knowledgeable, to make them feel okay that we're having to go through some of these same changes. And from a technical standpoint, you know, some of the docs really, they're not as comfortable in working with technologies. So I think we can be really valuable conduits and facilitators for the practitioners who are a little slow on the uptake. But perhaps, Nicole, you have other strategies that may help this particular requester.
Yeah, I think the key, at least in my experience, and I know Donna's seen this in organizations we've gone into as consultants, is really getting them to buy into it and participating in it. What I see across the industry is that oftentimes things are moving so quickly that we forget to pause and understand that if we do not engage the physician or the clinician in the initial conversations and get them to actually champion what we do, it's force feeding them to at the end. Once we get to the end and we're requiring something. So I really do think that our physician leaders and us as MSPs within our various organizations really need to have a high sense of emotional intelligence. And if we think that there are people that are going to be extremely resistant to this evolution or change in performance, data, measures, etc., I think we need to bring them to the table really quickly and ask for their input and ask for their engagement. Because if someone actually engages and actively participates in the development of measures or collections, they are obviously more willing to be on board and support movement forward. And I think we saw that with some technologies like voice recognition softwares like Dragon, right? We did see a large population of older physicians say, hey, I'm not going to take this on. I'm going to leave practice, or moving from paper records to electronic records. We did have some physicians that said, no way am I moving. This is too much change for me. And so then I think it's our responsibility as MSPs and in conjunction with the medical staff leaders to really work with those physicians on their exit plan out.
Mm-hmm. Yeah, and that's sad, but it is a reality. I mean, we know docs who didn't want to use the electronic medical record, and these were high quality practitioners, and they would rather resign than to have to understand how to work within an electronic medical record. So our goal truly as healthcare professionals is to try to help practitioners recover, give them the right tools that they need in order to stay engaged in providing care. Alex, any other questions? I know we're probably right now I know we got started a little bit late. We're right now at the 1 hour mark, but any other questions that we can field?
I don't see anything else here in the chat box, but if you do, feel free to email any of us with those questions and we can get back to you on those.
Yes, and again, we know that this was a lot of deep information, so thank you for allowing Nicole and I to begin the conversation, and that's really what this is about. Future programs, we'll break it down to smaller chunks for us, but we wanted to give you the big picture this first time around, and hoping to connect with you at next month's task force meeting. Nicole, any closing comments?
Thank you all so much for your dedication to not only what we currently do, but also kind of the evolutionary process of taking on additional responsibilities. We truly appreciate it, and if we all band together, I think we can do even more incredible things than what we're currently doing. So thank you guys so much.
Excellent.
Yes, and thank you both, Donna and Nicole, and everybody who joined us today. Like I mentioned, a recording of this webcast will be archived on the symplr website, and we will email you the link to access that. And your CE certificate will be in a separate email. So keep an eye out for that. And if you have any questions, feel free to email us at communications@symplr.com. I hope to see you next time.
Okay, bye.